I'm Ed Leadholt. My talk is Implementing a CT Radiation Safety Program in the Department of Veterans Affairs. My co-author in this presentation is Charles Anderson, the director of the VHA National Radiology Program. Dose to the population from CT imaging. There's been nearly a six-fold increase in the dose to the population from medical imaging since 1980. That's depicted by the small pie chart on the left in this slide. You'll notice that CT imaging was only a small fraction of the imaging in 1980. The much larger pie chart in the center depicts the six-fold increase in the radiation dose to the population from medical imaging. Please notice that the green half of the pie depicts the tremendous increase in radiation dose from CT imaging. A call to action. A number of professional societies, advisory bodies, and regulatory organizations have called for action to try to reduce the radiation dose to the population. The American College of Radiology issued a white paper on radiation dose in medicine in 2007. The Joint Commission recently issued a Sentinel event alert on the same topic, and guidance has been issued by many other agencies and organizations on this topic. The problem facing the VA. How to implement practices that reduce CT radiation doses to veterans in the largest integrated healthcare organization in the United States. We have CT scanners located at 152 medical centers and many of our hundreds of outpatient clinics. Cultural challenges faced by the VA. VA radiation safety officers were aligned toward regulating radiation safety regarding nuclear medicine and not X-ray imaging. Radiologists were concerned that dose-sparing techniques would lead to diagnostic errors. Practitioners did not feel comfortable discussing radiation risks with patients. Some didn't believe the danger was real. Some weren't able to answer questions about biological effects. And some were afraid patients would inappropriately decline studies. Technical challenges faced by the VA. One is the number and geographic dispersal of our VA facilities. We have VA facilities in each of the 50 states, out into the Pacific and into the Caribbean. We have a wide diversity of CT imaging equipment. We have equipment from all of the major vendors with a wide variety of ages and capabilities. We're not subject to oversight by state radiation control programs. They don't have jurisdiction over us because we're a federal agency. We have very few diagnostic medical physicists in our large organization. Most medical physics services to our individual facilities are provided by local medical physicists who merely test equipment. The U.S. Nuclear Regulatory Commission's practices have ensured that most radiation safety resources in the VA are devoted to radioactive materials and not to X-ray imaging. And some VA radiation safety officers have lacked knowledge about X-ray imaging. Resources in the Department of Veterans Affairs. We have the VA National Health Physics Program, which is a radiation safety oversight organization, and it has the capability of auditing our medical centers for compliance. There's the National Radiation Safety Committee, which is a policy and oversight body. There's the National Radiology Program that oversees our radiologists throughout our system. We have medical center safety staff and programs with radiation safety officers at most of our medical facilities. There are local champions for reducing dose to the patients, radiologists, medical physicists, and primary care practitioners. And the VA has the authority to issue and enforce policies through the Office of the Undersecretary for Health. Strategies for reducing radiation dose from CT scanning in the VA. First, we want to try to reduce utilization. We want to ensure studies are appropriate and avoid unnecessary studies. And we want to eliminate duplicate studies. We also want to reduce the dose per examination. This can be done by optimizing CT imaging protocols and by tailoring the imaging parameters to the individual patient. We want to prevent errors. We want to ensure that each imaging procedure is done of the correct patient using the proper protocol. The NEMA dose check standard available on newer CT scanners will automatically flag studies that may be about to give large doses to patients. And we can protect CT protocols with passwords to prevent inadvertent changes to them. This slide addresses utilization of computed tomography in the Department of Veterans Affairs. It shows that the utilization in the VA continues to rise even though it is plateaued in the private sector. CT rise is primarily in 60-year-olds. This slide shows the distribution of CT scans by age range. We see a peak in the roughly 60 to 65-year-old age range. We don't see that many CT scans done of people younger than 50. This is because in the VA we do not treat children and our emergency rooms are not equipped for handling serious trauma. You'll also notice that the age range is skewed toward higher ages and that the increase in CT imaging in the VA has primarily been in the 60 to 65-year-old age range. Appropriateness review. In the VA, each CT exam request is reviewed by a radiologist for appropriateness. Site visits to our VA facilities have shown good compliance with this expectation. Radiology order entry decision support software with automated appropriateness screening is being tested in the VA, but it's not widely available yet. So we rely on manual screening of exam requests. Optimizing CT protocols in the VA. We issued a guidance document on CT dose optimization in May of 2011 that described methods for optimizing doses from protocols. And we issued a memorandum directing all VA facilities to optimize their CT protocols in December of 2011. Dose optimization instructions to our facilities. We recommended that each facility form a protocol optimization team led by a radiologist expert in CT to review protocols and adjust them as appropriate. Each facility was requested to prepare a document describing each protocol, to eliminate unnecessary contrast phases, to compare measured CTDI vol values with American College of Radiology diagnostic reference levels and adjust the protocol parameters if appropriate, to consider the use of automatic tube current modulation for most CT studies. It should be used for nearly all body imaging. We recommended that our facilities create low-dose protocols for some follow-up exams, such as pulmonary nodule follow-up. We recommended that our facilities add password protection for CT protocols to prevent accidental changes to them. And we recommended our facilities implement the NEMA dose check standard, which triggers an alert or notification if designated dose values are about to be exceeded. Education and oversight. We conducted a teleconference with the VHA radiology community on optimizing CT protocols. We conducted a web-based teleconference for VHA radiation safety officers on their roles in CT oversight. We've implemented an X-ray safety audit program to monitor and advise and encourage compliance. It consists of day-long announced site visits by a medical physicist, and also of short audits after unannounced radiation safety inspections. Checklist for facility audits. This slide shows the CT portion of the checklist we use for reviewing an X-ray safety program. This is available from us upon request. An important aspect of a dose optimization program is the review of dose metrics. In the VA, software is under development to receive DICOM radiation dose structured reports, extract key dose indices, and store them in the radiology information system. From there, supervisors at individual facilities will be able to run management reports. Data will also be collected in the VA corporate data warehouse, which will allow calculation of dose reference levels for the entire VA. Patient education. We've prepared a one-page information sheet written for patients on risk from CT scans. A requirement for radiation consent is currently limited to potentially high-dose fluoroscopic procedures. We view any CT procedure that may cause deterministic effects to not be indicated. We don't have sufficient risk information to advise patients on relative risk of radiation-induced cancer versus misdiagnoses. We do not display CT dose metrics in the radiology reports from individual examinations. Still to do. We have considerable work left to do in the VA. We have to complete software to monitor CT dose metrics at both the facility level and the national level. Until we have this software in place, we have no method to demonstrate that we have actually reduced CT dose metrics across our system. We need to complete audits of all of our facilities. To date, we've done full day-long audits of about 15% of them. An area for improvement is that we need to promote the use of reduced kV for CT angiographic protocols. Our compliance audits have shown that most of our facilities are not using this dose reduction method. We're in the process of updating our CT dose optimization guidance document, and we're about to issue a memorandum directing that each VA medical center make CT dose optimization and dose issues an annual standing item to be presented at the Facility Radiation Safety Committee. Lessons learned. We've learned that this dose reduction effort must have the support of top leadership, both at the facility level and at the organizational level. The local efforts at each facility must be led by a radiologist expert in CT. Training is needed for key staff such as radiation safety officers and some radiologists. A medical physicist must be available for consultation, either by telephone or email. And site visits are necessary to assess and encourage implementation. And finally, I would like to acknowledge the following individuals who have played key roles in the VA's dose optimization program: David Burkett, Michael McNitt-Gray of UCLA, Aaron Angel, formerly of UCLA and now with Toshiba, Fred Metler, Michael Andre, and Rebecca Marsh, now with the University of Colorado. Thank you.